First off, I want to thank the brave men and women who work behind the wall. I want to thank them on a national level because their job goes unrecognized.
How do they try to turn a guard?
Well, correctional officer. Sorry, I apologize. But correctional officer.
How you guys doing today? It's Anthony Gangi. Welcome to another episode of Tier Talk. Guys, we got a good show for us today, guys. We're going to talk about the specifics of the COVID-19. I have Dr. Spaulding on. We have a lot to cover today, guys. We're going to talk about how we identify it, the difference between isolation and quarantine, how it's transmitted, basically the potential threat that we face coming into work, and hopefully maybe some updates on where we're at with maybe finding a cure, just a way to slow it down. My guest again today is Dr. Spaulding. She did a great video on my sponsors page, Guardian RFID, so I felt the need to definitely have her on the show. But if you don't mind, Dr. Spaulding, do you mind introducing yourself to my audience?
Hi, I'm Ann Spaulding, and I am a physician who has trained in internal medicine and infectious disease. My first job out of training was as medical director of the Rhode Island Department of Corrections, which is a combined jail prison system. And I also have a master's in public health from Johns Hopkins. For the past 15 years, I've been at Emory University in their School of Public Health. And my focus is the health needs of people who are in jails and prisons, and I am looking specifically at infectious disease issues.
Thank you, Dr. Spaulding, for coming on the show. I think this will be very informative. Hopefully we get some good information that you guys are able to lean on, and hopefully we find some hope. That's the key, because some of us, we do have to go to work. We are essential employees, and I'm trying to do what I can to give us the knowledge and just to kind of break you away from the sensationalism and bring you down back to reality. So now, guys, if you haven't, the show Tier Talks for you brave men and women that work in corrections. So please subscribe, interact, engage, comment, hit that bell. That bell's going to notify you every time I post a video. We're going to go to our sponsor, and when we come back, we're going to dive into COVID-19 and how it could specifically affect our prisons and jails.
I wanted to attend a university that had an intelligence program. I wanted to look at problems different. I wanted to increase my critical thinking abilities. AMU offered those avenues to expand. Obtaining your degree as an adult, you're actually paying yourself and investing in yourself. You can't put a dollar on it. It's priceless. It's something that can never be taken away from you.
American Military University. Learn from the leader.
Guys, inmate manipulation is a course that is highly needed. It's the process that's so slow moving and subtle that you don't realize it's happening. When inmates choose to manipulate, they manipulate our need to react. Situational awareness and insight is going to save your career. It's going to save you from doing foolish things. Listen to your gut. So the more insight we have, the more we can recognize what isn't so overt, and we can correct our behavior before we fall into a trap that we can't get out of. If you allow an inmate to pull you out of your prescribed role, you are opening up a door for a host of problems. Inmate manipulation, the psychology behind inmate manipulation. Available now. Link in description.
All right, and we're back. So, Doc, if you don't mind, can you tell us exactly what is the coronavirus and why is it called COVID-19?
So coronaviruses are a family of viruses, and most of the coronaviruses that we deal with are very benign viruses. There's I say group A and group B. It's basically the coronavirus. Alpha coronaviruses are the ones that cause a common cold. You get it, you get over it, and it's a nuisance, but it certainly doesn't stop the entire society. Then there's a whole different group. It's called beta coronaviruses. And the ones that are in that category are MERS or SARS, and now this new coronavirus that has not been seen before. And so it's the novel coronavirus, and we have named it COVID-19. And the virus actually, the disease is called COVID-19. There's a much longer, complicated name for the virus itself, but it's probably easiest to think of as coronavirus, and the disease it causes is Now,
I'm reading through your PowerPoint, which, by the way, is a phenomenal PowerPoint. obviously I like the fact that it's simplified so a layman like me can understand it. So you're talking about congregant environment. What exactly is a congregant environment? And does that include jails and prisons?
A congregate environment is where people congregate. And there are certain diseases that you would see where people huddle together and are in close proximity. And we work in tough environments, but we have similarities between jails and prisons and cruise ships, right? People are bunched together, living very close to each other, eating very close to each other, working very close to each other. So if you can imagine a infection that one person has, if it's moving airborne, it's something that everybody else is going to have pretty darn quickly.
Now, you obviously, you deal with infectious diseases. So what makes this infectious disease different than, let's say, tuberculosis, chickenpox, the regular flu, etc.?
The main difference is we know a lot more about the regular flu. We know a lot more about chickenpox, and we also know a lot about tuberculosis. Furthermore, all three of those pathogens, the two viruses and the bacteria, are ones that have treatment. So what we have right now is something that is new on the scene, not seen before, and we don't have treatment, nor do we have a vaccine.
Okay, now, obviously working in a closed environment like we do in corrections, how important is it for us to get control of this and get a handle on this?
I think the number one thing we need to do is partner with public health. And this is one of my greatest frustrations, being somebody who works in that bridge between corrections and public health. There are resources that the health department can extend to corrections that are being overlooked in many localities. Public health will have supplies. Public health will have the latest information being pushed down by the Centers for Disease Control to state health departments to local public health. And I think there's this perception from a lot of health departments. They say, oh, there's a medical person in that jail, therefore they can take care of this totally new infection. And they just don't have any idea of how complex the environment is within a jail and in a prison. It's like saying a cruise ship has one doctor on it, therefore we don't need to have the World Health Organization, the CDC, be trying to get that under control. This is something so far beyond what we normally have seen in corrections for centuries. We need to be partnered, and we can't be sequestered like we usually are in jails and prisons. I feel like I've been stomping my feet for about a month now, trying to get people interested in this. And now that COVID has gotten into correctional populations, and first correctional workers, and who have more contact with the outside, and now people who are living in correctional facilities as the incarcerated, all of a sudden people are saying, imagine that. And we could have predicted this months ago.
Let's say months ago, we kind of, knew this was happening. What would be the things that we'd be doing different?
I think there would just be more knowledge of what's going on, and this less of this kind of spooky uncertainty of what's going on. So protocols would have been in place. We would have some basic equipment that pretty much jails are getting a hold of right now. But we also would be more hooked in with what's going on in the community as a whole. So certain procedures and protocols as people come in, if it is a jail or a prison in an area where there's not a lot of local transmission, we still want to have every person coming in who's newly incarcerated, rolling up in a squad car, be asked, are you having a cough? Are you having fevers? Are you having shortness of breath? And then, have you been exposed to somebody? And temperature should be taken. As we have more ongoing local transmission, we should always be asking those questions of everyone coming in who's staff, but we also now need to start taking the temperature of staff coming in. So when you went to work today, did you have anyone take your temperature? If you're in an area where there's articles in the newspaper about COVID in the community, somebody should be taking your temperature, and ideally it would be with those infrared no-touch thermometers.
Now, where do you think at this point the threat is greater? At a jail, at a prison, or is it equal?
I think the threat is greatest wherever there are people that are infected. So I think I think if you were saying all things equal in a town where there is a lot of COVID going on, I always think that jails bear the brunt of the infectious disease issues simply because there's so much more churn. If you look at people going through jails and prisons, 95% of individuals that are going from the street to a correctional facility and back again, 95% of that churn is through jails and not prisons. So I think that's where there's much more unknown. So many people that are coming into a prison have been in a jail, so they've been studied before they are hitting a prison door. Of course, there are always some admissions from the street or from the court to a prison, but by far, I feel like the jail is a lot closer to street than a prison, and the churn is great.
Now, when we talk about the transmission, how is this virus transmitted?
Most of the transmission appears to be prolonged contact through droplets when people are within 6 feet of each other, when somebody's coughing repeatedly, and the virus particles through large droplets are landing on another person or landing on the environment, and somehow that droplet is brought from the environment up to a mouth, to a nose, or to an eye. That's how it seems to be the greatest exposure. So if you're walking by somebody who's not coughing, the likelihood you're going to get COVID is negligible. If you are having this intimate contact, though, with somebody who has COVID, so you might be, if you're in the process of arresting somebody who's coughing and just sneezing over you, who's very symptomatic, and you have prolonged contact, as you do when somebody's being arrested or kind of brought under control, you don't have 6 feet distance. You're right in their face. That would be the type of contact that I'm worried about. And we're talking about people who are symptomatic, who are the ones who are spreading this. Sometimes there are people who say, oh, I'm okay. And then maybe the next day they have symptoms. If you go back, often those people are starting to come down with symptoms on the day before they actually say, hey, maybe I do have something going on.
Let me ask, why 6 feet?
That's how far we tend to lodge viral particles when we're coughing and sneezing. These are droplets that are fairly large, and they tend to sink down pretty quickly. So there are some pathogens that are aerosolized and kind of linger in the air for hours and hours and hours. And this is not an infection that seems to be transmitted by hanging in the air for 6 hours like some other pathogens can. These are kind of big, heavy particles that are in the air and drop to the ground pretty quickly.
And it also lasts on a surface for a while too, correct?
It can. So as we're worried about what's going on, let's clean, clean, clean. If you have trustees who have a detail cleaning, get them to work, clean in ways that you don't normally clean. Think about everything that are the high touch areas, clean it as much as you can.
Now, in part of your notes, it says, and what you mentioned, sicker persons are more contagious, but it says that some spread before people show symptoms. if they don't have the symptoms, how does it spread? Like if they're not coughing, if they're not sneezing, how does it spread?
I think if there is some in the back of the throat and someone has a sore throat, they're just coming down with something, possibly that. I think this is kind of on the edge of what's known. I don't know if you're old enough to remember the cartoon Peanuts. Do you remember Peanuts?
Charlie Brown, of course.
Yeah. Well, you remember Pigpen in that?
Yeah, of course.
I think of the Pigpen, the guy who has is surrounded by a cloud. I think that's the person who's transmitting this. It's not the person that's not, if someone's not coughing and sneezing, they're not the big transmitters. It's the person that is just surrounded by a cloud of virus particles wherever they go. Those are the big transmitters.
Now, I'm going in order of your PowerPoint, but I want to break away for something. I want to get the questions asked. Hopefully, I'm trying to keep it like in a normal flow, but sometimes a question comes to my mind. I want to get it out there. We may just have to cycle back to where we were. But I'm thinking right now, let's say I was an officer and I'm working a unit, let's say a dorm, and I have an inmate that, has some symptoms. They're coughing, maybe feverish, whatever it is. So let's say I call medical. I don't know whether I'm going to have the nurse come to me at that point well, let's discuss that first. If I have one person that may have some symptoms and I'm the officer and I call medical, do I send the inmate over to medical, or would you recommend that the nurse comes to me?
So if you have a situation where you're working a unit and it might be a open contact unit where officers kind of in the middle on a desk and someone on the range is starting to cough a lot. The ideal situation is that there is a face mask that, not for the officer to put on. If there's one face mask, put that on the guy who's coughing, okay? Get him not to be spewing this stuff out. That's going to be the best thing to do to make sure that the officer is not infected, is stop it at its source, okay? Get that mask on the individual and then do an assessment. So I think what's most important is that if there is someone who's symptomatic, we want to get them away from others. And right now we don't have tests that are point of care tests, but those are coming. We want to get that individual so they're away from others. And if there's one mask, put it on the person who's coughing. If there are two masks, put it on the person who's coughing, have the officer wear it. And I would probably take cues from nursing as to what to do. So ideally, if individuals happen to be in a strange setting, I know this isn't usual, but if there are rooms with closed doors, if the officer could get that individual behind a door that is closed rather than a door that just like a normal cell door with just bars. So let's say if there's a room off to the side in that cell block, in that pod, in that housing unit, where there might be a closed door, there might be an activity room, I would get a mask on that person who's coughing and go put them in that room where they are having that door of protection away from everyone else, and then probably call the nurse on down.
So you actually made a very good point. Thank you for this. I don't know if you realize this, but I'm actually thinking now that after you just mentioned, maybe we should have some supply of masks given to the units or the housing officers, whatever it is. So in case something like that happens, they have a supply to give to the inmate who immediately needs it.
But let's say you are in the chain of command. Before you just go tossing boxes everywhere, I think there really needs to be some training as to what the box is for. Having somebody put on a mask to the point where they've been wearing it for hours and hours and hours, it gets all wet, it really is not doing anything. And I think my fear is that if there's just boxes around, all of the officers are going to just wear these masks that would not be doing much at all. But it would go on someone who's actually coughing. Someone clearing their throat for 1 second is not a cough. It's the person who is coming down with something like you hear when somebody's coming down with a cold. If they start coughing, then you can put the mask on. I think it all this depends on what your setup is. So there are some small facilities where you're so close to medical, you could just say, hey, let's go get a box over. There are some some facilities where there's so much space, it would be a big hike. And then maybe just having a box or a couple of masks per unit might make sense. But just make sure people are not wasting them. And just because you saw somebody on TV halfway around the world wearing masks all the time when they go shopping, that doesn't mean you need to wear masks 24/7. And it's probably going to do more harm than good to have a wet mask on for hours and hours at a time.
See, that's good to know, because obviously people are thinking the opposite. So it's great to have someone like yourself who, has the knowledge to kind of educate. That's what I'm trying to do. Again, give the, information out to my audience. But the other question I had too, and I thought you can maybe help me with this as well, is before we go back to the way your PowerPoint is structured, is if, let's say it was more than one inmate, let's say I had multiple inmates with these symptoms, when do we decide to act on universal precaution and either isolate or quarantine? And can you tell me the difference between both those terms?
Okay, so there are two terms that are, I think, really confused in our dialogue right now. One is isolation and the other is quarantine. Isolation, and we're talking about medical isolation. We're not talking about solitary confinement, throwing them in the hole. When we're talking about isolation, we're talking about medical isolation, and specifically in this situation, it's for COVID-19. Medical isolation is when you put someone who is possibly capable of infecting others in a situation where they have barriers so that transmission can stop. So if you have one person who has symptoms or has come back from the hospital and they say doesn't need hospital level care, but you can tend to this person, and you happen to have a negative pressure room, those rooms that you use for TB, the airborne infection isolation rooms, then you put that person in that room. If you have run out of your airborne isolation rooms or you don't have one, it's safe to put this person in a room with a closed door. And I think almost every correctional facility I've ever been in, from the ones that have 40 beds up to the ones that have thousands, has some room somewhere where there's a closed door. That's really what you need to keep people safe. And so you would put the infectious person behind a closed door. If somebody else is in the room, you want that person to be wearing a mask, and the person who's sick wears a mask, and the person who's coming in will wear a mask when they get within 6 feet. But isolation is where you put, medical isolation is where you put the sick person. Quarantine is where you put people who have been exposed, who are not sick, but are under observation. Okay, so if all of a sudden we go out walking, which is a safe thing, and it's a great way to relieve stress, is when you come home from work to go walking, but someone comes up to you, runs into you, sneezes, coughs, all of a sudden you've been exposed. Or if there's somebody in your household who's sick. So then you go on to quarantine, where you make sure that you don't develop the illness. You're asymptomatic, you don't have symptoms, and you are set apart from other people, but not put in the same place where someone who actually has the infection. And it's just a watchful waiting to see if you develop any symptoms. If you are in quarantine and you have no symptoms, it's actually safe for an officer to be in that area without gown, mask, gloves. So just walking by a individual who's on a cell block, who's in quarantine with no symptoms, it's fine. You don't need to be in battle gear for that. If the individual that's on quarantine is talking, singing, they're not going to be transmitting this infection if they're not infected with it themselves, if they're not sick. If they were to spit, just because they're unruly. And I hear these things happen. Actually, I've seen these things happen. I've been in corrections for 25 years. That's not going to transmit infection if the person is not sick.
What about the heat or the cold? What makes is it bacteria or what is it? What makes the virus survive outside of the human body? Is it more heat or?
Yeah, so basically this virus is a somewhat hardy virus. There's some viruses that are really fragile, and the minute they're outside of the host, they kind of disintegrate. And then there's some viruses that can stay around in the environment for days and days. So this is a virus that has an envelope. So some viruses are just naked genetic information, like a string of RNA with some proteins. This one has a protective envelope, and that's probably part of the reason why it can survive longer than other viruses. And it just is one that is probably kind of intermediate as far as hardiness. And so it's one that, because it can survive for a while outside of a host, you want to continue to make sure you destroy the virus, and it can be destroyed by so many different cleaners. There's all sorts of disinfectants that will kill it. There's cleaners that will wipe it away. You want to be using these on the surfaces just to keep your jail cleaner than it's ever been.
When we're talking about preventive measures, now we're going back with the structure of the PowerPoint. A lot of facilities are taking the temperatures of staff that comes in. Obviously, you highly recommend that, correct?
You bet. And I highly recommend that when there's COVID in the area. So every state now has COVID. At some point, fewer states will have COVID. And if we start getting to a situation where there's not COVID in an area, then and there's not ongoing transmission, I don't think we would necessarily need to be taking a temperature. But I think a lot of us like to work, and we have a good work ethic. And when people say, "You feel fine?" "Oh, I feel fine. I'm going to go to work." Sometimes just actually measuring a temperature, we really need that. We talk about absenteeism, where workers not coming to work. There could also be presentism, where somebody's coming to work when they should be at home. So yeah, I recommend it.
And why the temperature specific at 100.4 or 100.3?
Yeah, 100.4 is 38 degrees. It's just the definition that we use for fever. We have to come up with something that's abnormal, and 100.4 is not within the normal range. If somebody's 100.3, we're splitting hairs, the difference between 100.3 and 100.4. There are some people that are 99. Temperatures tend to be a little higher in the afternoon. I don't want to, there might be somebody who just happens to run a little higher. I don't think we need to send somebody home because their temperature is 99 degrees and they're clearly not sick, but 100.4 is not normal.
So we have here some prevention techniques. I'm just going to read it off real quick. It comes directly from your PowerPoint. Avoid close contact with people who are sick. No hugs, no handshakes. Avoid touching your eyes, nose, and mouth. Cover your cough or sneeze with the tissue, then throw the tissue in the trash. Wash your hands with soap and water frequently, especially after a cough. Wash for 20 seconds as long as it takes to sing happy birthday. Clean, disinfect frequently touched objects, surfaces. Follow CDC recommendations for using face masks, isolation of affected person, and all staff should stay off from work if they feel sick. Any comments on those preventive measures? Or
I think the only thing is that you're going to get tired of singing happy birthday. So I figured out Gloria Gaynor's song, I Will Survive. The last 10 lines of that also takes 20 seconds to sing.
I think a lot of people would take that advice. I actually have people next to me that were doing happy birthday. When it comes to the overview of symptoms and diagnosis, you says that many people are asymptomatic or only have mild symptoms. What does that mean?
So the majority of people who get this infection are not going to be on a ventilator. So the majority of people are going to get this and get over it. And so we don't want to get this infection. If we are going to get infection, we want it to be slowly rolling out over our population and not everybody getting sick at one time. But most people are not going to be like what we see in the news of hooked up to a ventilator and hanging on to dear life. Most people are going to get it, and who get it are going to survive. The issue is that some people will have a stormier course. And if we look at the older individual, the older you are, it goes up exponentially. So those of you guys in your 20s and 30s, the likelihood you're going to die from this is not impossible, but really low. 40s, 50s, it's a little bit higher. I don't know how many correctional officers are in their 90s working the beats, but if you're in your 90s, you have, we're starting to get rates of about 1 out of 5 people succumbing to the infection. Also, in addition to age, there are co-occurring disorders. So it seems like heart disease is one of the big ones. So people who happen to have heart disease seem to do worse with this. Also diabetes, lung disease like COPD. There's not been any definite evidence that I've seen yet of people with HIV doing poorly with this. People with well-controlled HIV, reconstituted immune system seem to do okay with this. And if someone has HIV and they're doing poorly, it's probably because there's another condition going on like heart disease, or they may be 50% of people with HIV are now over 50. So it may be just that they're older. So it's age and comorbid conditions, and heart disease, diabetes, lung disease, cancer are the big ones.
What about people with asthma?
I know that lung disease can be worse, and I'm not sure exactly how that's all going to play out. We do have a lot of individuals with asthma in our country. I think we're going to learn more about this. I would say if somebody doesn't have asthma versus someone who does, it's probably going to be a little riskier with people with severe asthma than people who don't have asthma. But we're getting into allergy season. There are going to be people that are going to be coughing. We're not sure. It's going to be hard to distinguish. Is it the cough from allergy, seasonal allergies? Is it the cough from COVID? It's going to be complicated.
Nick, when it comes to the symptoms and diagnosis, when you give off the tips, which I'll break down very shortly, you have the symptoms can appear as soon as 2 days or as long as 2 weeks after exposure. Average is 5 days. I wanted to ask a question about that, though. Why does it take quick for some and long for others?
You asked why some people get the symptoms really quickly after exposure and others have a much longer incubation period before the infection becomes manifest. That's what we normally see in most infectious diseases. So you've got a situation where you get infected and it incubates. So the infection is kind of brewing underneath the surface for a while, and then you start having some symptoms, and then the infection becomes full bloom. There are individuals that have a different ability to fight off the infections and fight off the symptoms, and they may just have a different genetic makeup. So there might be some host differences. There may be there may have been a different inoculum of the virus. So sometimes if somebody has a really big exposure to an infection, they may have their infection appear more quickly than somebody who doesn't. So it can be something to do with the infectious dose. It could be something to do with the host. That's what we see in almost every infectious disease.
And then obviously you mentioned some common symptoms: fever, cough, shortness of breath. flu-like symptoms. But then you gave out 3 good tips. Tip 1, vaccinate for flu, treat seasonal allergies so that you can distinguish what is illness that is neither flu nor allergies. Tip 2, patients can be co-infected with flu and coronavirus. And tip 3, make rounds of housing units to communicate with patients about new developments, what symptoms to watch. Though the one thing that you mentioned, tip 3, is such a great tip, because right now I feel that a lot of what's going on by the news is sensationalized, and maybe you can comment on like what the news is saying and what reality is. But what's great about what you said is taking the tours and educating the population, educating staff, kind of brings things back to reality and hopefully less pandemonium. But is reality different than what the news is saying?
Depends on what newscaster you have. There's somebody locally here that just has so much drama whenever he has any story. I've been listening to some of these clips on the internet, and it's like, oh my goodness, if only life were as dramatic as you make it out to be. It all depends. So I think just we're going to be living with this for a while. This is hopefully we're going to be maintaining the social distance for a while. We're going to allow this to play out slowly so that the medical systems in our areas are not going to be overwhelmed, where we will have, I'd rather see a slow, steady treatment of this rather than having a big spike of everybody sick all at once and overwhelming our hospital beds, our resources in our local medical center. So I think just the continuing just to let people know, yeah, if you're sick, we want to hear about it. Most of y'all are going to, if you get it, it's going to be a mild infection. And I think, if you have sufficient medical staff that are not tied up, it would be nice to have medical staff possibly address a cell block where people might be in their cells, and sometimes you can have a medical person talk to people who are along a tier or whatever. Correctional officers, I think this information can get out to people. There are some facilities that might want to play a video, and I know the video that I did for Guardian was really meant for correctional officers and medical staff, but maybe in the future we'll have more patient information for people who are incarcerated. It's things that bring down stress are visits with your family, being able to exercise, hanging with individuals, and all of these things are kind of being taken away all at once. It must be incredibly stressful for people who are not getting all the information, who are incarcerated right now. And for a correctional officer, taking care of people who are under stress is a lot harder than taking care of a unit where everyone is calm. So I think getting information out and just making sure that if anyone is sick, they get prompt attention is great.
Again, this PowerPoint's phenomenal. I'm just having fun going through it. You have levels of quarantine. I believe you have 4 levels of quarantine. What exactly, how do you break down each level of quarantine, and how does that specifically apply to corrections and jails?
So there's a schematic that was developed by Alaska Department of Corrections, which is one of the systems that has both a jail and a prison, where there is various levels of quarantine. When a sick, when there's a sick exposure to a sick person, the person who's well needs to be in quarantine where they're watched carefully so that they don't develop, so that if they do develop symptoms, that they will be cared for immediately. So if there is, let's say, an individual who is comes in, he gets picked up, let's say he was harassing people online, he may be a predator, a sexual predator online. He comes in, he says, oh yes, in my household, my mom has COVID, and I've been exposed to someone who's sick, but he himself does not have any symptoms whatsoever. That would be the situation where you have one individual who's exposed, who is brought into the facility. And you want to keep that person away from people who are unexposed. You also want to keep him away from people who are sick. So you want to have that individual as blocked off as much as you can from those two other groups. If there are negative pressure isolation rooms and you have nobody using them, if you put him there, he is certainly not going to be, if he does get sick, he's not going to be exposing anyone else. But he can safely be managed in a closed room. And you, what you would want to do is have that individual not be living with others, so you'd be in a single room, but you're wanting to make sure his meals are delivered to him, he'd be eating in his cell, and you basically don't want him roaming around your facility. Then there might be a whole group of folks that are exposed. So you may have a module level where a ill individual is identified in a single module, or maybe there's the marshal who has gone into a cell block and has exposed a number of people, or a correctional officer, or maybe someone who's doing maintenance. You want to quarantine all the individuals and keep them in that module, and then watch them carefully to see if they develop symptoms. And you want to separate them from the rest of the population. You serve your meals in that module, and you don't have them mingling with the rest of the facility. There may be multiple ill individuals that are found all over in many different modules. And if you have people exposed all over, you may have all individuals in the facility be quarantined, and you want to restrict movement around the facility until you can figure out, you want to remove the people who are sick, you want to watch the others, and just see if anyone else comes down with symptoms. There may be a situation where we're in a region, you might have one particular facility be the facility where you're going to be quarantining everyone. If there's a whole lot of people who are exposed, there may be a situation where a sick person goes from one facility to another, and you want to quarantine the exposed individuals, maybe in multiple modules in multiple facilities, or you may just want to say one facility is the module that we'll put in, one facility is a facility where we will put all of the individuals who have been exposed. So there are tiers, there are stages, there are different levels of how much quarantining a system needs to have.
Now, Doc, let me ask a question. When it comes to transporting these inmates, is there any specific way that you have to, protect the officers or staff that's doing the transport, and, with the inmate that's being taken out? Do they have to wear anything special?
Okay, so let's talk about the quarantined individual. If there is a individual who is under quarantine, and let's say you're taking them to for a legal proceeding or whatever, I think basically just putting a mask on that individual would be fine. I know that's what some of the facilities that have a number of quarantine people are doing. But generally, that would probably keep everybody fine in case they happen to develop the cough while they're a mild cough while they're being transported. If you have somebody who is ill, they're in the infirmary, and all of a sudden they're just looking like they're going downhill, and they need to be transported to a hospital, maybe a hospital with an ICU. I think at that point, they should be transported by rescue in the same way that you have other critically ill people be transported by EMS in your area. I think the situation that's difficult is when you have an individual who is ill, but there may be a limitation on rescue. The way to keep people safe is the same way that we transport people who might be under suspicion for TB. I think if officers are wearing masks, if the windows are down, if the sick patient is wearing a mask, I think in a car, in a van where there's air circulation, that's a lot safer than being in a situation where everyone is closed up in the same metal container.
All right, so before we come to a close, I have one last question. I'm probably going to definitely have to have you on again as we get these updates. The question I have now is basically where are we at with trying to find a cure or some form of treatment?
Right. There is a paper that came out where people are taking chloroquine. It's a very, very small study. In that study, there's one person who the authors say died. That actually happened to be the person who was taking chloroquine, not the person not taking chloroquine. So the comparison group, they don't talk about anyone dying. The one person who died was somebody who was taking chloroquine. I am not, if I started coughing, I would not personally go and start swallowing as much chloroquine as I can find. Chloroquine is something that has been tried in numerous infectious diseases. When people first heard about HIV, they were taking chloroquine. They heard about Zika, they were taking chloroquine. It's not necessarily going to be the panacea that's going to get this under control. I would say more research is needed, and the best way for our society to take care of to learn from this situation, I know people may want to take chloroquine, is to have people take it in a way where some people will be getting it, but also it would be done in a controlled way where we can be monitoring how those individuals are doing. And in a randomized controlled trial, we will learn whether or not it's more good than harm or more harm than good. And I think we need to be studying this a lot more before we start treating people who are incarcerated, treating ourselves with chloroquine. I wouldn't go ahead and start downing chloroquine.
So how far are we really from finding something?
Yes. I wish, as far as a cure, it's 30 years since we've had the HIV epidemic, and we still don't have a cure for HIV. There are other diseases where we get a cure pretty quickly. We do have cures for influenza. We have cures for chickenpox. I mean, there's a lot of illnesses that we do have cures for. There are other illnesses that we don't have cures that are that have been developed. So, if I had a magic lantern, I'd be able to tell you what's going on. I don't have a crystal ball to look into the future, but certainly this has the world's attention, and things tend to happen when you've got a lot of smart people working on things. And so I remain hopeful.
I like that. That's a great way to end it, by the way. Do you have any last minute thoughts for our correctional staff out there, the inmate population, just maybe some ideas of what they need to do and maybe just another level of hope?
Wash their hands. It's our best defense.
All right. Thank you, Doc, for everything. By the way, I just want to thank you for what you do. Obviously, for you to get this information, you're also putting yourself at risk. We noticed that. My community noticed that. We're forever grateful for people in the medical field. I'm grateful for you for giving me the time. And I'm also grateful for you for the sacrifices you make to get that information. So, again, thank you, Doc. Much appreciated for what you do. You're a hero in my book.
Well, I appreciate your getting the information out and your interest in trying to keep everybody safe. These are hard times.
And by the way, guys, she did this at the last minute. I just called her and she said, let's make this happen. So thank you for finding the time to do that. Now, guys, Again, I hope you take this information. You may have to watch it once or twice, but we're just getting more information in as it comes. And as always, guys, the show is Tear Talk. If you haven't, please subscribe, interact, engage, comment, hit that bell. Bell's going to notify you every time I post up a video. And stay safe, guys.